Good evening, everyone, and welcome to the EPA webinar, Bringing It All Together. We are so excited everyone has joined us tonight. We will start the webinar promptly at 6:01 to give a few more people time to log on and join us. Again, thank you for joining the EPA webinar, Bringing It All Together. We will start the program momentarily. Good evening, everyone. It is 6:01, and I really appreciate everyone jumping on the webinar tonight, brought to you by the Eastern Pain Association, Bringing It All Together. We are so excited you have joined us tonight, and we're going to turn it over to our moderators. Gentlemen and ladies, take it away.
Thank you, Michelle, and thank you for joining us today. I am Christopher Garibo. I am the president of the Eastern Pain Association and the medical director of pain medicine at NYU Langone Health. I'm joined today by my good colleague, Dr. Neil Maida, who's the president-elect of the Eastern Pain Association and medical director of pain medicine at Weill Cornell. And this is our Meet the Pain Fellowship program directors gathering, and we hope to make this of great value to you by giving you good advice in terms of how to apply for a pain medicine fellowship, how to go about the interviews, what is the faculty looking for, what is pain medicine like as a specialty, and what is training in pain medicine about, how is it different in the COVID era and above and beyond. I'll take the next slide. So we have divided the program into 3 separate sessions, and this is the first time we're doing this. So please give us your feedback and give us your questions to maximize the value to everybody on the line. You'll be learning from the program directors, and we'll be learning from each other, from you, as well as from other programs as well. This is all about how to make the training program more valuable to the trainees, as well as cross-sharing information and knowledge, as well as ideas about how to improve pain medicine training and present an interdisciplinary front to our other colleagues and to fellows and to our patients. The first session is going to focus on pain medicine fellowship application and how to go about optimizing that as you go about interviewing through different programs within the programs that are here, as well as across the country. The second session is going to be about pain medicine training and how to optimize that training, both from an interdisciplinary perspective, from a disease state, from a pharmacological, non-pharmacological, and interventional perspectives. And this third session is going to be career planning and practice of pain medicine, and how to go about, for example, choosing between academic versus private, and other facets of pain medicine that you may consider as a career choice. Now, I would like to introduce our panelists. I'm going to introduce them by name, and then subsequent to that, I'm going to give them a couple of minutes to introduce their programs. We are joined today by Dr. Charles Argoff, a good colleague of ours from Albany Medical College, by Dr. Lena Matthew from Columbia, who's the pain medicine program director there, Dr. Amit Gulati from Cornell, our pain medicine fellowship director at Cornell, Dr. Syed Wahazi, who's the pain medicine fellowship director at Montefiore, Dr. Shengping Zhao, who's the pain medicine director at NYU Langone, and Dr. Donna Ann Thomas, who is the pain fellowship director at Yale. And before I give them the microphone, I would like to thank our Allergan, the makers of Botox, who has made this program possible, and we're highly appreciative of their efforts. And we'll start with Dr. Argoff in introducing his program, and then take it from there.
Sure. It's great to be here today. We probably have the smallest program. We only accept 1 fellow per year. And we're in the capital of New York, near upstate New York. We have a very strong multidisciplinary program with lots of experience. I am a neurologist, so I'm a little bit different probably from many of the other panelists in being a neurologist who's program director. And that program is based in neurology with great interaction with anesthesia, physical medicine, rehabilitation, and neurosurgery. And I'll just stop there and let someone else tell us about their program.
Sure. Dr. Matthew? You're muted.
Thank you. Thank you for that. Take two. I'm Lena Matthew, as Dr. Garibo mentioned, and I'm over at the Columbia University Medical Center's Division of Pain Medicine. We have 3 pain fellows every year, and our fellowship is open to candidates who have successfully completed their residency training in anesthesiology, psychiatry, physiatry, rehabilitation medicine, or neurology. It is an ACGME accredited program. It's multidisciplinary, has multi-specialty training, and it focuses on both the medical and the interventional aspects of pain medicine, while also sort of allowing for outside rotations in the fields of palliative medicine, neurology, physiatry, and physical medicine. I think that's sort of the program in a nutshell, and I'm sure there'll be opportunities to divulge more about the program as our webinar continues. So thank you.
Thank you, Dr. Lena. Dr. Glady?
Thank you, Chris and Neil, for allowing us to have a moment of brevity in talking about these kind of programs. We are at Cornell University, Cornell College School of Medicine, have 8 fellows, and we rotate through 3 different sites at Memorial Sloan Kettering Cancer Center, Hospital for Special Surgery, and Weill Cornell New York Presbyterian Hospital. And the fellows have one of our biggest strengths of our particular fellowship is the diversity of patient population that you get to see, and also the opportunity to work with many different pain attendings, rehabilitation attendings, neurosurgeons, interventional radiologists throughout the fellowship. So the breadth of experience is what we really hope to impart to every one of our fellows.
And Dr. Vahazi? Syed, are you on the line? Okay, we'll move to Dr. Zhao, Shenping Zhao.
Hi, Chris. Thank you very much. Nice to see everybody. So our NYU Pain Medicine Fellowship Program, we have 6 positions. And so the fellow rotates 3 hospitals: NYU Langone Medical Center, Bellevue Hospital, the city hospital, and VA hospital. So we have very diverse faculty. Not only the patient population very diverse, we have a diverse faculty as well. 14 faculty, pain medicine faculty. We have 3 of them PMR background, and we have 1 psychiatrist background, and the rest are anesthesiologists. And also we collaborate very closely with neurosurgery, with palliative care, and we are the multidisciplinary pain fellowship program. The fellows specifically, they have distinct rotation with neurology, rehab, psychiatry, and anesthesiologist faculties. So they had really a true multidisciplinary approach and experiences.
Thank you, Dr. Zhao. Dr. Thomas?
Chris, can you hear me now?
Yes, now
yes.
unmuted. Very good.
I'll circle back to you, Seth, shortly.
All right.
Yes. So we have a fairly small fellowship program. We accept 2 fellows per year. Our current incoming fellowship group is 1 with a neurology background and 1 with an anesthesiology background. We do have a multidisciplinary fellowship program that rotates through the VA hospital, Smilow Cancer Hospital, Children's Hospital, and Yale New Haven Hospital. We have distinct rotation in physical and rehab medicine, psychiatry, anesthesiology, neurology with a headache focus, and also neurology with an EMG focus, and a neuroimaging radiology rotation as well. Our fellows will get experience and in working with both the faculty who are academic as well as a community-based PM&R faculty as well. And I look forward to answering any questions that you may have.
Thank you, Donna. And Dr. Wahazi?
Thanks, Chris. I apologize for not getting on earlier. I was pressing unmute, but it just wasn't working for me, but I appreciate your patience. So I'm a physiatrist. I'm a PD at Montefiore, and I think we have a fairly unique program, probably a little bit different from everybody else's here. I mean, everyone's has their own strengths, and ours, I think, lies in the fact that we are multidisciplinary in a sense that we have a panel of about 10 pain physicians that our fellows work with on an almost daily basis, comprised of anesthesiologists, neurologists, physiatrists. We have an ancillary staff of psychiatry as well. We're a very busy practice. Pre-COVID, we saw about 14,000 patient visits and we performed about 5,500 procedures. That being said, my mission in the fellowship is not for fellows necessarily to do as many procedures as possible, even though our fellows do a lot. My mission is to make sure that we're choosing the right patients for procedures so that we can have the best outcomes, possible. We also have a very tight relationship with our spine surgeons as well. About half of our clinics are run with orthopedic spine and neurospine together, and we cross-refer on the same day in those clinics. I'm looking forward to having a very thoughtful and engaging conversation with the panel and also with the residents and fellows as well this evening.
Great, thank you, Syed. And now I'll have Dr. Mehta run the first session on pain medicine fellowship application. Neil?
Thank you, Chris, and thank you to the audience for tuning in, and to our panelists today who were fortunate to take time out of their schedule to join us. I'm sure the first thing that comes on to mind for everybody listening in today is just how are we adapting to fellowship application and interview processes. And so I want to take a little time to have each one of you discuss that. First of all, how have you decided to conduct your interviews? Are you doing in person? Are you doing it by phone, virtually? Are you doing it panel? If you can each one of you take a moment to answer that. We'll start with you, Dr. Argoff.
Sure. We are actively conducting interviews. We are using Microsoft Teams to conduct those. We actually had interviews on Friday where we interviewed 6 candidates. We had a member of the neurology department, that was me, and program director interview, neurosurgery, physical medicine, rehabilitation, anesthesia. We had 5 actually separate interviews, and we were able to interview each person rather seamlessly in half-hour intervals from discipline to discipline. We had a lobby, so each interviewee had a break in between, and our IT staff was fantastic, and it was really a seamless experience. It was actually really a lot of fun. So we're doing it through Microsoft Teams, virtually.
Great. Dr. Gulati, how are you conducting that?
We were originally hoping that there was an opportunity to see people in person, but clearly for safety reasons, we've transitioned to a virtual-based system as well. We'll be conducting our interviews in July at some time on Friday, so we haven't started our process yet, but while Cornell has already done a lot of interviews for other specialties, on a Zoom platform, and also how to logistically have multiple interviewers and interviewees throughout schedule through the day, similar to what Dr. Orgoff is talking about. So we implementing what Cornell standards are right now through Zoom, but the idea is the same, to have a schedule for the interviewers and the interviewees, for the applicants, a break time, and most of our decision making will be based on a Zoom type interview.
Great. Dr. Matthews.
Sure. I was just joking with our fellows, our current fellows, that it's impossible to say anymore that I'm not digitally savvy or technologically savvy. I mean, our reliance is completely on digital technology at this point. So we've, embraced that opportunity, and it's been going pretty well, actually. So, of course, I mean, the one-to-one, person-to-person interview is obviously the best way to sort of assess whether or not someone is a good fit for the program. But given the limitations that we have currently, we're using Zoom as a platform, but also integrating Microsoft Teams as a platform for all of us to sort of communicate on paper, seamlessly in terms of like rating the candidates and having like all our opinions and everything going on a rolling basis there. So what I've been doing is I send a webinar link to a pre-recorded sort of introduction to the fellowship program, which all the candidates receive like within 48 hours prior to coming in and interviewing with us. On the interview day, all our faculty are present and our fellows are present as well. We use Zoom. I usually spend about 10 minutes at the start to sort of welcome the applicants and then just go over some of the questions that come up based on that webinar. And then they just break out into breakout rooms where we have interviews with the single faculty as well as with panels of faculty. We have fellows that are placed in a separate breakout room so that the interview candidates that are not being interviewed have an opportunity to sort of like talk to the fellows in a group setting and get sort of questions answered, and they can talk in total privacy, no snooping ears, and they can familiarize themselves with the program like even better and understand whether or not they're a cohesive fit for the program. And once the interviews are wrapped up, we get all of them out of the Zoom rooms, and then we have all the faculty getting together and sort of inputting our impressions into Microsoft Teams. And then, I can keep using those Microsoft Teams based info going forward. So I've had about 52 interviews in June, and we have a couple of days coming up. Yeah.
Great. Thank you, Dr. Matthew. Dr. Thomas.
Hi.
Hi.
So we will be interviewing every Thursday in July, and we're using a Zoom platform for our interview as approved through Yale. We've had some experience because we've already started lots of interviews using Zoom. So we have a really great media team and media head who has been able to coordinate our interviews for us. We interview in teams, so we'll have teams of 2 multidisciplinary faculty who will be interviewing an applicant at one time, and that person will interview with multiple different teams during the day with a touch base with the program director. So every applicant will get an opportunity to speak with the program director for a short period of time and also interview with the team. And at the end, we'll virtually have a discussion regarding the candidates.
Great. Thank you very much, Dr. Thomas. Dr. Zhao. Dr. Zhao, if you're on.
Hear me?
Yes,
Can you hear
thank
me
you.
now? Yes?
Yes.
Okay, good. So we select about 110 candidates invited for interview, and we started from June. So we use the NYU approved platform that's WebEx. So it's a virtual interview, and we set up in such a way which have been done for the last 2 years. We use the MMI interview format. I mean, if you guys doing the medical school students interview, that's NYU does. And that's how we use the same format. So each candidate they go through 5 stations. Each station is structured in 15 minutes, and each station they have a very unique question. So in the end of the day, and each candidate get the independent scoring from interview, and then we tabulate the score according to that, and we make a ranking list. And that's how we did in the past, and this year we do the same thing. The virtual interview seems so far is pretty smooth. We're able to interview like 20 candidates per day. So far we tomorrow is going to be last one, the major one. So we interview probably about 90 so far, and the feedback is pretty positive from candidates. We do have some logistic issues to get the faculty, to get a fellow involved, and but so far it's pretty smooth. Also in between, you know, each session, morning session, after session, in the end of the session, we have virtual lunch with the fellows, with our current fellows. They can log into the fellows, they have group chatting with the fellow, they can ask all the questions they want. And also, I interview every one of them. I give introduction. Dr. Grebo also got involved. He introduced the program to everybody. So and we had a good experience so far. Please.
Thank you, Dr. Zhao. Dr. Wahizi?
Thanks. Historically, my program interviews very much on the later side. We interview in mid to late August, and this year is not going to be any different. We do that really for administrative reasons and logistics. Lucky for us and lucky for me, many of the panelists here today are good friends of mine. So I'm going to be learning from them as to what has worked for them and what hasn't. The way that we think we're going to be doing our interviews this year is that it will obviously be a virtual format. The format will be one of either 2 platforms. It'll either be Zoom in a panel type of format where me and about 4 or 5 other interviewees will be in the room, and we will collaborate on the interview in real time. The virtual platform will either be Zoom, or I'm going to be a little bit different and introduce the idea of doximity because it is HIPAA compliant, and you can get your interviewees in real time. Unfortunately, they won't have the ability to be in breakout rooms, but there also is less incidents of hacking and other kinds of disturbances with doximity as compared to some of the other virtual platforms. So that's probably the way that we're going to go this year in terms of the virtual format.
Great. Thank you all to all the panelists there. We took a couple questions from the audience. One of the questions that came up was that perhaps in this era of virtual interviewing, that it will be easier to attend more interviews. And will there be less cancellations? Will you find it more challenging as to how many interviews you're going to conduct? I open this to the entire group to be able to answer anything that they may have regarding whether this is going to lead to potentially more difficulty getting interviews, or the opposite, that you may have unmatched positions.
Neil, who do you want to answer first?
I allow the group to answer, whoever wants to step up first.
We don't have to go in order or have all of you respond.
Yeah.
Just time.
I mean, just
Okay.
You're muted. I see you talking.
I can take a quick answer. I think for all of us, this is going to be a very challenging year to determine whether we're going to interview less or more, or how to interview, or how to even rank candidates. All of us are learning how to interact with patients on a regular basis through telemedicine. And so I have a suspicion that we'll learn a lot from the interview process this year to determine how things would go for the following year. My personal gestalt is that it's going to be a very trying time for people who really like to get to know people one-on-one, face-to-face, and use a lot of body language as part of their communication, to now to really rely on communication through a web-based system. So I have a feeling there's going to be a lot of challenges. We haven't changed my criteria for interviewing, and so we feel that we've still maintained our criteria, which was never web-based to begin with, and we haven't noticed a drop-off in the actual applicants saying yes to an interview. But I have a feeling the rank list will be different than prior years because our decision-making will be very different. It may be more, maybe not be as organic about a feel for meeting someone, but may still rely more on the entire application.
I agree. We haven't changed our criteria for application as well. But I completely agree that making a rank list this year will be a little bit more challenging in terms of not being able to have, especially reading body languages. It's really challenging to do that virtually. It's a one-year fellowship, and it becomes challenging if you choose a fellow that is not the right fit for your program. And it's important to find those fellows who are going to be the great fit for the program. So one of the things that we're going to focus on is complete transparency, as well as to make sure our fellows know, or our applicants know, exactly what they're in for, what the program is, what their rotations are. And so there will be no surprises if they so choose the program, and they will know also the expectation of the fellow. And then we hope that by doing that, we will have the best fit for our program.
I'm going to change on the subject of rank list. A question came up about how can we become more confident if we are our top choices, top choice. So top programs, top choice. And what's the best way of communicating the top choice to that respective program? What would you want to see? And I open this again to the group.
Neil, for clarification, you asked that question as if you were the fellow, correct? Or rather the resident, who is asking, how do I let the places where I've interviewed know that they are my top choice? Is that the question?
Correct.
Okay. May I answer that?
Please.
Okay. In my experience, what's worked very well is sending an email to the program director. Most fellowship directors will hand out their email addresses, and our email addresses are accessible to most anyway. And if you've been interviewed, you probably have that contact. And just sending number one, an email soon after the interview, but also maybe about, I don't know, about a week or two before the date where our rank list is due, may be very helpful.
Good. They're related to that. Is there advice on, and this is, I'm going to read the question as written to me from a applicant. What are the program director's advice for closing the ranking list? Is it really true that match is based on the applicant's preference, and the applicant should not think about in which program they have a higher chance of being matched? Dr. Matthew, thank you.
Yeah, I mean, this is a question that comes up often on the interview trail, and I always say, I mean, this is really, the match is really about the applicants and their preference. And they really shouldn't play any games in terms of like strategizing in terms of where, like which program is more likely to take them. If they love a program, if they feel they're a fit for the program, I mean, be authentic, go for it, be passionate about it, and like rank that program number one. And hey, if that program feels that you're the right fit for them, they'll probably end up ranking you pretty highly as well. And your chances of matching, I mean, that's the whole purpose of this match. It's to really find a match that fits you. So I would encourage fellows to our residents, our applicants to just go ahead and match like as your heart like sort of dictates.
Good advice. I think that wraps up the application process questions. Chris, I turn it back over to you for the second session.
Sure. Thank you, Neil. I'd like to transition from fellowship application to pain medicine training and optimization. And the transitional question would be, what are the qualities you're looking for in an applicant and in a fellow? And has COVID changed that in any way?
Are you asking us, Chris?
Yes.
Okay, I'll be happy to jump in. I think that many applicants are clearly very interested in pain medicine and pain management training from an interventional point of view only. And that would not be a good fit for our program. Not because we don't offer, we have more than enormous. We have two of the most important, we have a lot going on and more than enough procedures. But I think pain medicine at Albany Med is a very well-rounded experience. And you're going to be trained to do many procedures. But we are going to emphasize the importance of getting to know the whole patient and getting diagnosis you're treating and getting to know that when your procedure doesn't work, you don't walk away from the patient. I'm a nut about that. And maybe because I'm a neurologist and we always have that. I'm a neurologist who does things, but still. And so I think that we are going to really, a good applicant and a good fit for our program is one who's really interested in being part of a team taking care of the whole patient. So if somebody comes and isn't the right for a STIN, they're referred to another person in our program immediately, and we kind of fit it together. So that's the kind of thinking we want to have.
Yeah, that's great feedback, Charles. I think it's very important to emphasize that to our trainees. Any other colleagues? What are the qualities you're looking for in a fellow, and has COVID changed that?
So I completely agree with you. I often emphasize to the fellows that pain is biopsychosocial, and it's not just being an interventionalist that does not make a good pain provider. Because if you're an interventionalist, oftentimes then when the procedures fail, and we oftentimes get these patients who their doctors do not want to treat them anymore because the procedures they did failed and there's nothing else that they could offer. So our fellow needs to look at the patient as a whole and look at other factors. And a good fit for our program would be someone who are looking at nutritional factors or smoking cessation, daily physical fitness as well, in addition to the physiology of what's going on and possibly intervention. So I completely agree.
I agree with both the two speakers. I mean, I think it's very important, especially during the COVID era. I mean, ACGM, the one goal for pain medicine, training a doctor is compassion care. I think that's a mission of ours, and it's our goal to train a physician like that. The COVID actually really strengthened these convictions for pain medicine, because really you demonstrated caring, compassion about the patient, not just about the injections. You really take the patient as a whole, and the team support, working ethic and professionalism, communication skills. So all this kind of, the trail should be, select good pain fellows.
Thank you, Dr. Zhao. Anybody else?
Yeah.
Chris, I just wanted to highlight one of the things that I've noticed. I agree with the panelists that we're looking for really well-rounded residents and fellows to train. But one of the things I've noticed in the last 4 months, I think has become a little more critical, is really learning adaptability and really learning how to deliver and communicate healthcare in a wide variety of virtual ways, how to monitor opioids virtually. And you really have to have some forward-thinking innovators in your fellowship for the next few years that we can groom so we can optimize some of the ways we deliver pain medicine for the future, because it sounds like it's going to be very different in the next few years and perhaps even further. So one of the newer things I've been kind of thinking about is trying to groom a set of physicians that can adapt to kind of a really rapidly changing environment in our field, not just interventionally, but really in the delivery of healthcare, whether you're going to do virtual teams, virtual tumor boards, virtual or second opinions from far away places. It's going to be a very different way of delivering healthcare, probably that's going to be accepted in the next 5 years. And those are the kind of things we want to look for when we're training, regardless if you're training at Cornell or any of the other programs. Really, that's a quality we would like to really focus on going forward.
Yeah, thank you, Amit. Any other colleagues?
Yeah, Chris, I'm going to chime in on this as well, because I think it's actually important for everybody here to say something, because I think it's really valuable to the listeners this evening, because they're all interested, I think, in our practices and how we've developed it and how we're moving it. I'm going to echo everybody's sentiments and say that, I believe that being well-rounded is absolutely key. We are, as I've mentioned before, an extremely busy interventional practice, but the best interventionalists and the busiest interventionalists know one thing in pain medicine, and that is that it doesn't always work, right? If one is moving to treat pain medicine with the tool of having a needle or these new percutaneous devices, many of which Amit and I have worked with and are developing, and even though we're doing all those kinds of things, we have to understand that they're not going to work all the time. And then you have to ask yourself the question and make the fellows ask the questions. Well, what do we do if this doesn't work? And then all of the other strong points that were brought up earlier about nutrition and comprehensive care, nutrition, weight loss, exercise therapy. All of these points are important. I'm a physiatrist and I do a lot of physiotherapeutic education in the rooms when I see my patients before I offer intervention. I think diagnosing the issue is extremely important, and whether that diagnosis is psychosocial or if it is mechanical, once one is good enough to diagnose those things, then one also has to have the system to direct the patient to one of those two arms, one of the myriad arms that treat pain. So I do think it is extremely important. Now, to answer the question specifically, what are the things that I'm looking for as a fellowship director? Authenticity and adaptability. Authenticity, because I believe we're a very honest and very good program. And adaptability, because sometimes when our strategy A or strategy B doesn't work, then we're going to need our creativity to adapt to then be able to treat our patients by avenues C or D.
Thank you for the great advice, everybody. This is very valuable. I'd like to follow up with the following. There's a lot of concern about the procedural volume and the office volume, and absolutely we gotta get the pain, but everybody's concerned about their technical skills and their interview skills and physical examination skills in the COVID era. This whole thing may settle in a couple of years, but at present it is still a concern. How are we adapting to the COVID training environment with expected diminished in office volumes and maybe even procedural volumes? What is different about this year?
And maybe to expand on that, is there any alternate teaching tools? Maybe how do you integrate them into telemedicine? Are there simulation platforms that you're using that the fellows could learn on?
This is definitely going to be one of those years where we will have to draw on pretty much like every learning modality there is to improve learning agility for our fellows. I mean, we will have to probably collaborate in ways that we haven't collaborated before, in terms of like just didactic learning and maybe even rotations, observerships, conducting workshops. We've been dabbling a little bit with simulation-based learning, and I think that platform is definitely going to launch a lot stronger this year. And doing even simulation-based, case-based learning on a case discussion sort of platform, doing it virtually, I mean, there may be some value to that as well. But I'm definitely going to say that collaborating with other disciplines and programs in order to like optimize the educational output's probably going to be the most important thing this year.
And so we already had the advantage last year of having collaboration with the Acute Pain Regional Anesthesiology Fellowship, but also having a monthly ultrasound didactic program at the VA for our fellows with a faculty who is ultrasound fellowship certified. So certainly incorporating those things. But one of the very interesting things that we had to learn to teach is how to do a physical examination virtually, especially a pain physical examination. That itself can be very challenging, especially when you're trying to determine the appropriate types of procedures that needs to be done on a patient who is in pain with multiple pain generators, and choosing the right type of procedure, but being only able to examine the patient virtually. So those are definitely new techniques that I see even outside of COVID is probably going to stick around for a while in terms of telemedicine. And as we adapt, I think it's one of the skills that our fellows need to learn.
Guys, this is Said Wahizi here. May I chime in on this at this point?
Please.
Okay. Donna, thank you for the transition, and now for the shameless self-promotion that I'm going to present here. Charlie and I just recently
Thanks for doing this. Thanks for doing this. Thanks for doing this.
Yeah, John, we both, Charlie and I, appreciate this. Charlie and I recently published an article on the musculoskeletal and neurological exam in telemedicine for the pain practitioner. This was accepted about a week and a half ago. We worked on this for quite some time, and it will probably be in print within the next month to month and a half. I know that Pain Physician is actually working on this, and they will probably, and they're working on this to make this a rapid publication. So it'll probably be available online before it actually hits the tangible copy, so to speak. So we have developed techniques, recycled old ones, and then kind of made some better visual techniques to try to educate practitioners on the musculoskeletal and neurological exam. I agree with you. I think that it's going to be extremely important. And actually, what Charlie and I created is we believe that it's groundbreaking, because the way that we put this together is a way that no one else has actually put a manuscript together like this in this format. So I encourage you to take a look at it. I'm going to hand out copies to my fellows during orientation tomorrow, just so that they can kind of have a beat on this. But I believe that telemedicine is here to stay, and that we're going to need these tools in order to both teach ourselves and to teach our trainees, because when they're going to be looking for jobs, in about 7 or 8 months' time, I think having this as a tool makes them very valuable. So I do think that we should implement that. So in terms of the kinds of things that I'm doing in my fellowship, based on COVID-related changes, from an educational point of view, obviously educating them more heavily in telemedicine and video medicine. Number two, from the didactic point of view, I have friends who are PDs in the Midwest and in the West as well, and we are actually creating a Zoom platform for didactics, where once a month we will be covering topics that each one of our groups don't see much of. We don't see very much pelvic pain, and we don't see a lot of some of the other key words that are on the exam. So the other places in the country are going to be helping out with us, and we're using actually COVID as an opportunity to latch into those other programs and their knowledge base to improve ours. From a procedural point of view, I believe that if you can teach someone to do 10 procedures correctly, it's better than teaching them 100 procedures incorrectly. And that's the way that I've always operated. So our volume will probably be down this year. How much, I don't know. That's going to be determined, by COVID and COVID-related changes and what other kind of systematic and healthcare changes it prompts. But we are probably going to be having breakout sessions. I've purchased 2 models for my fellows where they can practice when we're not in the procedure suite. So those are the things that I've made available to my trainees.
Thank you, Syed. Any other thoughts about how to compensate for the expected decrease in volume?
Chris, I just wanted to chime in. Wonderful thoughts from the rest of the panelists. There's very few silver linings with the pandemic, but one of the things that we noticed is that in the last couple of months, we were able to rapidly restructure our program. Things that we're thinking about to do over a few years, we're thinking about doing the next 2 months. And so one of the benefits of working in our facilities is that we have multiple pain physicians who are doing various clinics, various procedures that did not have any fellows training at those sites. So we've been able to redistribute our fellows to those sites. But perhaps we've kind of changed our tactics as well in how we train our physicians. We're rapidly changing from a cadaver-based training program into a model, so synthetic model training program, using some of these models that are available and that are available commercially, and so they can practice their procedures both under fluoroscopy, and then we do live model training under ultrasound. We've been doing that for years. And one of the few things we've been doing with our educational programming is that we've been using the help of different societies. There's some various societies that have been very helpful in education. I don't want to name all of them, obviously, but one of the societies, the World Academy of Pain Medicine Ultrasound, or United now, has an entire telemedicine webinar teaching series. So similar to what Dr. Argoff and Dr. Wahezi are talking about in terms of manuscript, we actually have physical exam videos on how to do a physical exam examinations through telemedicine for head and neck, for shoulder-related pain, for knee-related pain. So there's various societies that are providing a significant number of educational opportunities that we can really take advantage of, with World Academy of Pain Medicine United being one of them. And there's significantly other ones that are really taking the lead on providing virtual education that can really supplement a fellowship's education.
Yes, I'm hearing a lot of virtual teaching, potentially decrease in volumes, ways to compensate for that. What are the plans for the programs in terms of the didactics? Are they going to be by webinars? Are there going to be any face-to-face teaching and didactics and case conferences and journal clubs?
I'll jump in and answer this one just because I'm going to take the opportunity again because it was quiet. In my fellowship, yes, there will be face-to-face. We've got a fairly large conference room, and we've got a screen that's about 72 inches, and we project onto that. We have 6 fellows, and the 6 fellows plus a couple of anesthesia and PM&R residents. Sometimes a medical student in our particular room will still have about 6 feet distance between one another. And Cuomo actually did officially recognize 25 people as being okay, a couple of weeks ago. So in my program, I didn't see a reason to go only virtual. We did do this in the height of the epidemic here in New York, but I don't see the need for that now. Since my fellows came back from being away to the floors and away from the pain center for about a month, taking care of COVID patients, we have actually transitioned over to face-to-face didactics, journal clubs, Q&A sessions, M&M and the such.
Thank you.
I'd echo that we're able to do the same in Albany.
Okay. Any other colleagues?
Sure.
Please.
Yeah, so our goal is to really just get into more of a hybrid model. The Zoom, the interactive digital platform seems to be working really well. It also gives our fellows a sense of security in terms of not having to sort of congregate with other people. So when it comes to didactic sessions, which really needs face-to-face interaction, by that I mean there are sessions that focus on physical exam and so on. I mean, in those sessions, we'll have our fellows come in and attend like face-to-face sessions. So we're really trying to do like a hybrid sort of model here.
Any other colleagues?
Chris, I just wanted to chime in real quick. One of the advantages of having things transition to telemedicine is now we have access to other people's teachings throughout the hospital. So for example, our fellows can now go on to the bone metastases tumor board, the spine tumor board, and other tumor boards are occurring in the morning and the afternoons that before it was physically very difficult to attend, but now you have access to it. And most of these conferences are recording these things and having them available for their fellowship. So now all of a sudden a neurology discussion happening in the neurology department is accessible to a pain fellow. So if you really, what we've done, in at least since I'm at Sloan Kettering, we've gone through all the oncology tumor boards, find out what times they are, what kind of educational platforms they're using, and having the accessible opportunities for the access to our fellows. So it's really allow you to open up your entire breadth of pain medicine. You can attend a rheumatology discussion now that may be occurring in some other part of Weill Cornell, or a orthopedic surgery discussion on spinal fusions that perhaps you would not have attended, but now a fellow could, even for 30 minutes during clinic. So really it's to open our ability to transition to educational opportunities beyond just our own field.
Thank you, Amit. The next question I have is that how do you train your fellows in an organized fashion with respect to appropriate billing and coding?
Chris, I can take that. We actually have, yeah, we've been doing this pretty regularly, actually mid-year and at the end of the year. Sorry, beginning of the year, mid-year, and end of the year. Those are the 3 touch points that the fellows have to sort of talk to the billing and the coding specialist. So we have a representative, the woman who kind of runs the billing and the coding services in our department. So she comes down, she basically goes over all of that, and then we have like one of her faculty members also attend that, so they do understand how best to like bill, code, you know, go through like what the reimbursement policies are, what needs to be documented in order to sort of maximize like your, you know, the billing returns. And we do that through the year, like in these 3 sessions. And with each session, I think the fellows know more in terms of what they need to ask, what they need clarification on. And before they were ready to launch into practice, they have a fairly good understanding of that.
Any other colleagues?
Yeah, for us, for NYU, so we have 2 billing sessions. One billing session is the billing company, which is you know, doing for anesthesia department from outside, the company's outside, and they give a talk about regular billings, about pain medicine. And then the second session, we have our own institution. We have billing department. They have billing audit. They come into our department and give a talk and order some billing, and then went over each, you know, the medical notes with billing codes. I think was very useful for the fellow and for the faculty.
Thank you, Dr. Zhao. Here's a broad question. Is 1 year of training enough for pain medicine as a specialty? We talked about the interdisciplinary model. Pain overall is very complex. Training is highly focused on interventions. Is 1 year enough to get it? And if not, what do we do to make up for it?
Donna, I saw you smirking, so you take this. I'll take it right after you.
I mean, this has been in a debate since I was a resident. There were thoughts that it either should be a 2-year fellowship or pain medicine deserves its own residency program. And while you can argue the value of both of those things, we are, you know, stuck fiscally or financially with a 1-year program. And it's very challenging to get finances to support otherwise. We have a T32 program here at Yale, a very extensive T32 program that we are quite willing to get a candidate who will do research as well as the fellowship, and that will extend the amount of time that they are with us. We have not had a candidate as yet, but we do have the capability of doing that. But no, 1 year certainly isn't enough because pain medicine in itself is complex. And you can, it's really understandable that there's really not much appreciation for the complexity of pain medicine by many of our counterparts until you do pain medicine itself. But I believe it will continue to be a debate for a while until there is some long-lasting change.
Yeah, Donna,
I'm just
I
gonna chime in before what Hazy does.
Mhm.
I'm still a fellow. I'm still a fellow. I'm only learning from these panelists and learning from Dr. Verheyse, Dr.
I learn
Argoff,
from
Dr.
you all the
Matthews,
time.
Dr. Thomas. We're all with a fellow. So I'm going to chime out now. Go ahead.
No, Amit, go. Amit, go.
That's all I had to say. I think we should look at pain medicine as always something we're learning, and the field is rapidly changing. We're always learning. So regardless of your fellowship, you're going to be using various other modalities to continue learning, no matter what. Find your mentors.
Yeah.
But along those lines, before you say anything, but along those lines, I said goodbye to our fellow today, and I said, know your limits. I said, don't know what you don't know. Don't do what you don't know. Be humble. And to the point that was just made, you're constantly learning. And
Yeah.
it's not like, it doesn't matter how many years it is, there will be new developments. You'll never know everything.
Yeah. You know what though? I think if we were our own residency, or if we extended the fellowship, and I don't think this will ever happen, but I think that we'd understand what we're dealing with a lot better, right? I mean, look, we've got to understand surgeon speak. We've got to understand psychiatry speak. We've got to understand physical medicine rehab. We've got to understand principles of acute anesthesia, right? We're looking at, and that's, I mean, those are just things that, you know, I can rattle off at 7 o'clock on a Monday. There's probably many, many more, right? And we're expecting our fellows to learn this in 11 months. Right, and 11 because you have to include vacations, you know, as part of an ACGME accredited program, and then you consider, you know, the ancillary programs that the fellows have to go to, you know, the outside rotations, and you're looking at 9 or 10 months. Okay, and honestly, I don't think it's enough. And Donna, you know, you've got a 232 program, and I think it's a shame that, you know, we have to announce these things and that there aren't enough people who want to do research because. You know, most of the research in our field is being done by private practice. Yeah, and there's you know, there's nothing wrong with private practices doing research, but really, you know, I think that academia should take the lead on this. And I think possibly the nature of what we publish and how we publish these things can make changes in how learners learn and how information is presented. And yes, you know what? I think that all fellows should know their limits and all fellows should be humble upon graduating. But I think that if we were to extend, if somehow we were able to extend our academic borders and our teaching borders, then maybe we'd need a little bit less humility because we understand so much more. That's my 2, 3, 4, 5 cents, nickel, half dollar, whatever it is.
And just before anybody else is chiming in, I just want to say thank you so very much for having me. Unfortunately, I have to go. I look forward to collaborating with you all, and feel free to email, text, and ask any questions that you may have.
Thank you for
Thank you,
joining
Dr.
us.
Thomas.
Thanks, Donna.
Thank you.
Hey, Tana. Bye-bye.
Bye-bye.
So one final question before we transition to the next session, which is pain medicine as a specialty. Where did your graduates go? Private, academic? What kind of a practice did they set up?
So in my fellowship, it's been about 50-50. I've been the PD since 2000, and I can't even remember, I think 12 or 13, I think maybe 13. And it's been split it's been split, academia and privates. I think we prepare our fellows well for either arm. Chris, actually, you're getting one of our fellows this upcoming year, who's fantastic. And so, yeah, that's where they've gone. And I think, you know, every one of these panelists on the screen today will attest to the fact that if you've got a good fellowship, then your fellows can go in any direction post-grad.
Thanks, Syed. Any other colleagues? Where did your fellows go?
Yes, we've had a good split as well. About 30 to 40% of our fellows go into academia and stay in academia, and about 60 to 70% of our fellows go into private practice. And you know, there is a little fair amount of jumping between, like, you know, you're in private practice for like 5 years and then you come back to academia, or you've been in academia and then you like jump into private practice for a variety of reasons. But I always assert, like, I mean, you could be in academia or private practice and you could still be educating the community. You could be educating your patients, you know, indulging in research. I mean, you could still be making like some significant contributions no matter which area you choose to go into. Most of our fellows come in and they're pretty, at least through the interview process, I have almost 100% of our fellows saying, you know, we want to do academia, but somewhere along the way, the lure of private practice is pretty strong. And around the 8-month mark, they usually get into these private practices and I totally understand why they choose the private practice over the academic practice. You know, it's understandable. Yeah.
Thank you, Lena. Anybody else?
Chris, our fellows are this year, 4 fellows are going in academic practice or academic hospitals, 4 going in private practice. And I echo Dr. Matthews' comments on there's these academic private practice kind of scenarios it's a very wide breadth of differences. I like to think of academic practice as a lot of bosses and a private practice is a lot less bosses. That's pretty much my only gestalt, because I think just like Dr. Matthews said, you can do a lot of these things in terms of research, in terms of education, working with societies that you can do either in academics or in private practice. Our field tends to have more of a fluid movement between practices, whether they're in an academic setting or not. And a lot of the academic setting practices are becoming more like a private practice and vice versa. So I think you'll see a kind of a hybrid formation in our pain fellowship and pain medicine, and our fellows have accordingly gone and become academicians in a private practice and vice versa.
Thank you, Meet. So we were playing a short video. That's going to automatically mute everybody. So right after the video, please unmute yourself, and I'll have Dr. Mehta take over the next session on career planning and pain medicine as a specialty. Take it away, Neil.
Is the video playing?
Yeah, it did. It played already.
Oh, it played already. Okay, I missed that. So we are going to talk a little bit about career planning and practice of pain medicine. I do want to just take 2 questions that came in a little bit earlier on the first session, which was the interviewing process. When is the ideal time period to email your #1 program? I think Dr. Wahizi answered that really well, so I'm going to just try to cut to the chase on that one, in that shortly after your interview, as you think about your rank list, is a good time to reach out. Make sure you're not emailing about 30 different programs that they're #1, because people talk. Second question is, will the virtual platform lead to a preference for internal candidates when it comes to ranking applicants, or will all have equal chance? And unless somebody feels differently, I would say that everybody has equal chance among all the programs, and I encourage people to be optimistic and hopeful about that. We've already sort of hinted at where the graduates are going and talk a little bit about career planning and practice of pain medicine, whether this is affected for the long run or just the short run with COVID. One of the questions that came in was, what does practice look like 2 years from now to 5 years from now? How does the job market change? I think we've already seen a lot of dynamic changes in pain management, even from before, when we had private practices being acquired by hospitals and even private equity things. Here's your chance to speculate as a panel and tell us what you think.
I mean, you look like the most imposing figure here, so I think you should go.
Yeah, now you take a step back. I was kind of hoping Charles would chime in because he's probably seen like 3 generations of things go up and down. He can tell us what's happening.
Wait a second, I'm not that old.
No, like I remember when I was a college student and I had a master's class in bioengineering where my attending was an ophthalmologist developing a virtual eye at the time. And he told me how medicine was dead because HMOs had just taken over. This is like early 1990s, I guess. And he told me, it says, don't go into medicine. HMOs are taking over. There's going to be nothing. There's going to be no financial reward. The death of medicine is coming. Then I went into wanted to do radiation oncology when I was a medical student, and the radiation oncologist there were telling me the death of radiation oncology was coming, that cancer treatments are going to solve everything and there'd be no more cancer in 10 years. So I think the idea that we can predict 5 years of pain medicine is very daunting. Dramatically, things change. The one things we can kind of focus on and project is what Dr. Mehta was alluding to. The business aspect and the financial aspect of things will direct where the resources are going to go. So if telemedicine and phone visits and telemedicine visits are equivalent to a in live or in-person visit, it will allow you to have a certain kind of practice, versus if the payment schedules go down dramatically, you may not have a very big telemedicine practice, or you're going to have to readjust the finances to make it fit in your practice. And those kind of things was kind of what dictates how pain medicine goes in a practice setting, because in the end, you have to be able to pay for the services that you are providing. I do think that there's more collaboration. There's a lot of different specialties that interact with each other much more now than perhaps 10 years ago when I was first a fellow and an attending. So you're seeing a lot of development of ideas from, Dr. Vahezi and I on rehabilitation and bringing interventions in rehabilitation and techniques that we're taking from regional anesthesia and applying to cancer pain medicine. There's a lot more opportunity of collaboration with someone like the rest of us who are doing various things that perhaps 15 years ago was a little bit more difficult to collaborate on in terms of communication. So I think there's a lot of beauty happening in pain medicine, where a lot of different specialties who come into taking care of pain have come together. So as an independent practitioner, you can offer a lot of different things that you probably would not have offered 15 years ago.
Charles, you can't stay silent that long. Give us your prediction.
I think there are going to be a lot of different models. First of all, there may be regional differences. So in Albany, we are the only tertiary care center for millions of people who can't go to New York City, aren't going to another big city, but maybe 3 hours away. So for us, I can see that we may be doing many more phone visits and telemedicine visits for initial assessments, treatment planning, integration with local primary care providers, and maybe a local provider who may be able to do a simpler procedure, like a facet injection or epidural, transforaminal, whatever is appropriate, and that we may see our practice being more focused on more the advanced procedures. And we'll all, the last point that was made, we'll plan together and we'll become part of groups. But I think a lot of what happens is going to be, really think about it. For those of you who are in New York City, I used to live in Northport, in the Huntington area. Wouldn't it be better for me to be evaluated by you, Neil, through a first visit telemedicine than, it took me longer to go from Northport, Huntington to Manhattan than it takes me to drive from Albany to Manhattan because of the traffic. You know what I mean? So there are so many reasons why, and then what, you know, the business and practical and patient satisfaction reasons why we can marry technology, our ability to do procedures, improve our efficiency. I mean, really, if you spend an hour with a new patient, it's very important, but you know, we're all also being subject to considering how we can make our practices productive in other ways. So I think it's gonna be a fun time over the next 5 years to figure out how to make it work. But I think it's gonna be very dependent upon where you practice.
Yeah.
So from this COVID, I really see a lot of alarming signs and warning signs about if we continue what we're doing right now as a pain doctors, I mean, we're really gonna be in major problems. Let's say New York City, right? 3 months shutdown. So, okay, so outpatient visit changed to telemedicine. Okay, big deal, but everybody else does. Now, our outpatient procedures almost completely shut down for 2.5 months. I mean, there's no major impact on patients. I mean, you can say we can say what we want. How important is the intervention pain procedures? But this is elective procedures that was able to shut down for 2.5 months. There's no impact. And patient actually, inpatient, we did have business inpatient. They didn't call us during even peak of the COVID. They call us for consult. We were able to maintain our inpatient service, and we rendered the service over there. So this gives me a lot of warning signs. I mean, we have to be flexible, approachable. We cannot cherry pick on what we want to do as a pain doctor, as a specialist. And we just need to meet the community need, meet the patient's need. And if we have this kind of basic concept, and make us look essential service, because in a way, it is a pain service, looks like we're not an essential service, and then any time we can get major issues.
Who wants to follow that sobering thought?
There's one thing, there's only one thing that I know very, very well, and that's that I don't know enough. Okay, and I don't know what's going to happen and what is going to be the future of medicine and pain after this. I philosophize a lot, and actually I put some of my thoughts in a paper that was published a couple months ago in Pain Medicine about what may happen because of COVID. And I believe that what Charlie said earlier was right, and that it's easy for patients to be evaluated by, it's easy for patients to be evaluated when they're at home. I think that payers understand this as well. And I think that institutions appreciate this now also. I think that medicine is probably going to transition to much more telemedicine care. I think that it's going to be up to us as practitioners to then be able to target who the people are who need that visit, maybe based on an initial or a follow-up telemedicine visit. I think that's going to be on us. I think that until there are papers published showing that telemedicine is dangerous and that people are becoming, well, more ill because of it, or that it's costing industry more, we're not going to lose telemedicine. But I think that those publications are probably years away, unless something devastating happens and we have that information before. But I don't know anyone who's collecting it right now. But I'll tell you that insurance companies probably are already on it. They've already pressed the go button. So I think telemedicine is with us. I think that is probably going to be true for at least another 1 to 3 or 4 years. Beyond that, I don't know. In terms of pain medicine, I agree with Amit that there is a lot of collaborative effort. One of the things that COVID has done and COVID has done brilliantly, ironically, is that it's brought people together and it's brought thoughts together. Right? We may not be sitting here and having this discussion together if it wasn't for COVID, right? Because who would have known? I mean, I've never been on GoToWebinar before this. I've Zoomed once or twice, but now for me, Zoom is like a daily thing. You know, when I told you earlier that we're having didactics from colleagues from across the nation and possibly across the world sooner than later. These are things that probably would not have happened if we did not have the devastating effects of COVID. I think that there are good things that have been brought about from it. I think only time will tell how good these good things are in medicine.
I think there needs to be some guidelines with respect to telemedicine and how it's going to be utilized. At present, we're probably overcompensating and just seeing an excessive number where it's too easy to miss a myelopathy or progression of neurological disease. And I think a string of bad experiences is going to make us pull back. But I do agree, it is here to stay. Many post-procedural follow-ups, for example, can be done by telemedicine. Chronic opioid therapy is another area that sort of needs to be explored further. How much is okay within telemedicine and how much should be handled on a face-to-face basis?
Charlie will tell you that he can now pick up a myelopathy over the phone.
After our paper.
Yeah.
That was a little bit facetious, okay? Although you might think, I mean, back to what I mean, you know, we're talking about this, but might there be people, a hybrid model might be a community, you know, people going into, you know, either a mid-level provider going in, you know, doing daily visits to people's homes and doing this, or local, partnering with a local primary care provider who may be guided by things like maybe our papers, you know, that's what he's, you know, maybe that, and then we're really reaching out and working together with that assessment for myelopathy, neuropathy, radiculopathy, et cetera, will be done in a collaborative way in real time. Right. To your point, this may have brought us all together in a real way.
I agree. I agree.
I also want to comment on during the COVID crisis, pain medicine sort of got pushed to the side. We were seen as being purely elective. And that certainly was not the clinical experience and the feedback that we got from our patients, where they came to us with flare-ups of CRPS, acute sciaticas, and truly severe pain that needed intervention, where these cases were clearly not elective, but urgent or emergent. So there will be a paper coming out. I think a lot of good things came out of this, where there'll be an acuity classification, where pain medicine is not purely elective, but acuity classification needs to be performed on the patient, so that if somebody needs a blood patch, they need to get that blood patch. Otherwise, they can't function. They can't take care of themselves. They can't food shop. They can't walk. So I think we really need to gear up with the literature so that we're ready for COVID recurrence and other pandemics.
I also think this really briefly that if you want to, sometimes the best way to show the benefit of the treatment is to have the absence of it and have people out and say, I need it. So for those of who manage pumps or do injections and botulinum toxin use, I can't tell you how many. First of all, we had to take care of people. We managed many pumps, and those individuals with spasticity, chronic pain, we didn't stop managing them. We didn't stop treating people with their migraine. And when we had to delay it, we heard from the patients, to your point, Chris, that we're suffering and we need your treatment.
Yeah.
I mean, I think one of the things we have to really think about is decide our decision making in pain medicine has got to change. Now we were heavily reliant on history and images, right? When I have a telemedicine, you're really going to have to talk about the historical context of what disease processes were happening and when to get an image. And based on those two decision criteria, that's when you come into the clinic to do a physical exam or do a procedure. And I really got to rethink how before an image might be a supplement, an MRI or X-ray. Now it's going to be the primary history and imaging, and then the exam is going to be secondary. So we've really changed how medicine was delivered 100 years ago when a physician went to the house to do the physical exam, listen to a heart, and now look at the fingertips. Now you're really reliant on the history of it and asking those physical exam questions that you probably did in your paper or showing on the video screen. And you depend on your imaging criteria, like what your MRI shows, and then make a decision whether to come. And that's really a different way of teaching and practicing. It's going to be probably easier for pain physicians who do interventions because your patients will come in. But for physicians that don't have to have an actual presence to prescribe, that's going to be very difficult to start having patients come in for medication that perhaps can be easily distributed over a telemedicine kind of environments. This is my concern of medicine in situations where you may not necessarily need a patient to come in for a medication to be delivered. It might devalue that aspect of medicine, which is my number one concern in medicine with this new kind of telemedicine basis.
And I think another opportunity here for telemedicine is to project our specialty beyond the immediate geographic region and maybe even use it as a marketing tool and as a screening tool for our practices to gauge the appropriateness of the referral. And that came up multiple times. It sort of dawns on you as you're doing telemedicine on a new patient. Hey, I'm really not the right doctor for you, but I know where to send you. And you didn't have to waste a visit to see me during the pandemic.
Absolutely. Great. Well, I think that about does it for our session 3 and our questions from the audience. I want to thank the panelists for taking their evening to meet with us, and also for sharing your wisdom with the applicants. And it's going to be interesting times for us as we go forward. Chris, if you want to talk about the next date that we have.
Sure. Yeah, thank you, Neil. And I would like to thank all the panelists as well and everybody that has attended this program. And I'd like to make a pitch for the Eastern Pain Association. There are many good societies. Eastern Pain Association focuses on interdisciplinary care that all of the program directors brought up. In pain, you don't just treat the pain, but you got to get the pain and understand where it's coming from. And it can have a variety of different pathologies, many of which really need to be addressed through interdisciplinary care. So through our annual meeting or through our other educational efforts, we try to bring it all together in terms of what that interdisciplinary care is. So I would like to echo that sentiment. Support the Eastern Pain Association, and we're also highly fellowship focused and young trainee and a young physician focused. In getting started with your career, it's important to learn the different facets of pain medicine, whether if it's the underlying disease state or whether if it's pharmacodynamics or interventions. But you need experience in that, and you need experience from leaders in the field. In our annual meeting, in our case reports, in our case discussions and case panels focused on that. So we'll be having a fall meeting focused on interdisciplinary care that will be extensively broadcast. I don't have the date off the top of my head, but we're going to be pinning that down soon. And there will be hopefully a future Meet the Pain Medicine Fellowship Program Directors focusing on different parts of the country as well. I do think that as a society that we're extending beyond the eastern half of the country, not just the eastern border, but our model applies broadly, obviously nationally, and we'll be projecting that. And with that, if I can have you, everybody in the program, please answer this quick poll and state how you heard about this webinar. And I would like to again thank everybody who served as the program director panel, and thank all our attendees for this successful program. And enjoy your evenings.
Thank you so much.
Thank you, everybody.
Thank you.
Thank you all. Bye.
Bye-bye.
Bye-bye.
Thanks, everyone. Have a good night.
Good night, Michelle.